After this course, you will be armed with a simple, validated approach to thoracic ultrasound. You will be able to apply this at the bedside tomorrow to accurately diagnose the cause of your patient's respiratory failure in less than 3 minutes. You will be a Jedi Master of lung ultrasound. The lungs have a large surface area and wide projection on the skin. Air and water are intimately mingled in thoracic pathology. This interface creates artifacts and signs that are easily recognized. This, coupled with the understanding that the major causes of respiratory failure have characteristic air-fluid ratios, forms the basis for lung ultrasound in the critically ill. Bedside ultrasound is so valuable because acute disorders tend to have superficial locations. Pleural effusions and pneumothoraces always reach the pleura. Acute alveolar consolidation touches the chest wall in over 98% of cases. And acute interstitial disorders involve not only the deep tissues, but the subpleural areas as well. To utilize the technology effectively, it is important to become familiar with the language of lung ultrasound. Comfort with these 9 signs defines fluency in the field. The first is the BAT sign, which is the starting point for all lung ultrasound. A-lines and lung sliding define the normal lung. The quad sign and sinusoid sign identify pleural effusions. The tissue sign and shred sign describe consolidation and atelectasis. B-lines are present in all causes of interstitial syndrome. And the lung point is specific for pneumothorax. We'll discuss each of these signs in more detail. Every thoracic ultrasound should start with identification of the ribs. The probe should be placed perpendicular to the chest wall in the longitudinal plane, with the probe marker toward the patient's head. This allows identification of the superior and inferior ribs and their acoustic shadows. The ribs are 2 centimeter archiform hyperechoic structures, 2 centimeters apart. The pleural line is a horizontal hyperechoic line, half a centimeter deep to the vertebral rib line, and represents the parietal pleura. All signs arise at the level of the pleural line. The BAT sign, created by the ribs and pleural line, is the basic landmark in lung ultrasound. There are many ways to divide the sonographic projection of the lung on the chest wall. The method you will learn today was pioneered by the godfather of lung ultrasound, a French intensivist named Daniel Lichtenstein. It is derived from his Blue Protocol, published in Chest, which demonstrated the diagnostic power of bedside ultrasound applied to patients with severe dyspnea. Lichtenstein talks about using the blue hands to identify standardized points on the chest wall for an efficient analysis of the anterior lung. He calls these 4 points the blue points, the upper blue points and the lower blue points. Imaging at just these 4 points integrates the notion that pneumothoraces and interstitial syndromes have a wide projection. The upper blue points correspond to the upper lobes, and the lower blue points to the middle lobe and lingula. The third point of investigation is called the PLAPS point. PLAPS stands for posterior and/or lateral alveolar and/or pleural syndrome. The point is located at the intersection of the posterior axillary line and the continuation of the lower blue point. It detects the huge majority of both small and large pleural effusions and 90% of acute alveolar consolidation in critically ill patients. It locates to the lower lobes. Now that we have discussed probe positioning, we'll move on to the findings that define the normal lung, A-lines and lung sliding. The pleural line divides the image on the left in 2 parts. The top is the true reconstruction of the chest wall. The pleural-air interface is a strong reflector of ultrasound waves. The bottom image is an artificial reflection. The space deep to the pleural line is called Merlin's space. It can be occupied by either artifacts or anatomic disorders, depending on the underlying process. A-lines are horizontal repetitions of the pleural line at precise distances. These artifacts signify air deep to the pleural line. They can represent normal lung, the lungs of patients with airways diseases such as asthma or COPD, or pneumothorax. The pleural air interface is a strong reflector of ultrasound beams. To the ultrasound machine, time is distance. The beam bounces off the pleural line and returns to the probe. It is absorbed and creates a line at a certain distance. If the beam bounces back and forth twice before it is absorbed, the course takes twice as long, and the machine interprets this as a structure that is twice as deep. A-lines signify air deep to the pleural line. This can be normally aerated lung or a pneumothorax. The second characteristic of the normal lung is a dynamic one, lung sliding. To see this, find the best image of the ribs and pleural line and hold the probe still. The movement of the visceral pleura relative to the parietal pleura generates a shimmering or gliding or sliding motion. This is normal and excludes a pneumothorax. The M-mode correlate on the right is the seashore sign. The M-mode finding is supposed to be reminiscent of a relaxing sandy beach, because this excludes pneumothorax at the level of the probe. Absence of lung sliding is suggestive, though certainly not diagnostic, of pneumothorax. The M-mode finding on the bottom left is the somewhat foreboding stratosphere sign. The next two signs identify pleural effusion, which occurs in up to 61% of medical ICU patients. Pleural effusion is traditionally identified by its anechoic nature. However, life-threatening causes such as empyema and hemothorax may be echoic. The quad sign is an abnormal, dependent image above the diaphragm with 4 regular borders. It is bounded laterally by the upper and lower rib shadows, superiorly by the pleural line, and deeply by the lung line, which represents the visceral pleura. The sinusoid sign on the right is a dynamic sign that represents the respiratory variation in the interpleural distance on M mode. It is specific for pleural fluid and indicates low viscosity and the ability to perform a thoracentesis with a 21 gauge needle. The plankton sign and jellyfish sign also dynamically identify pleural effusions. Ultrasound is superior to chest X-ray at identifying the presence of pleural fluid and quantifying the volume. A validated equation to estimate the volume of pleural fluid in mechanically ventilated patients involves measuring the end expiratory interpleural distance at the lung base and multiplying this number in millimeters by 20. Ultrasound can guide safe thoracentesis even in mechanically ventilated patients, assuming the quad and sinusoid signs are present, there is no organ interposition, and the interpleural distance is greater than 15 millimeters at end inspiration. Consider performing thoracentesis in your ICU patients in the safe triangle as an alternative to the conventional seated position, guided by ultrasound. Ultrasound is excellent at characterizing the nature of pleural effusions. In general, transudates are anechoic. Anechoic effusions can be either transudates or exudates. Complex septated or echogenic effusions are exudates and should be further evaluated in febrile ICU patients. Echogenic effusions are typically hemorrhage or empyema. Alveolar consolidation gives rise to two characteristic patterns depending on the extent of disease. With acute consolidation, over 98% of cases abut the pleura. Placing the probe at the PLAPS point detects 90% of such cases. With lobar consolidation, the deep interlobular septa are thickened and surrounded by alveolar fluid, generating a tissue-like pattern. Sublobar consolidation gives rise to the shred sign. The upper border is the pleural line. The deep border is shredded and irregular. It represents the interface between consolidation and aerated lung below. Next, we will discuss artifacts generated in interstitial syndromes. The B-line is a comet tail artifact arising from the pleural line that is well defined, hyperechoic, and moves with lung sliding. It erases A-lines and spreads to the edge of the screen. B-lines are an important finding. They indicate interstitial syndrome and exclude pneumothorax. B-lines are generated by thickened interlobular septa. Normally, the interlobular septa are too fine to generate artifacts. However, when the septa become thickened with fluid or fibrosis, the ultrasound beam is trapped and undergoes a to and fro movement that generates small lines at each movement. The summed result is a long vertical hyperechoic line, the B line. B lines are associated with pulmonary edema, either cardiogenic or permeability induced. They appear suddenly when a critical amount of fluid is reached. They occur in all interstitial syndromes. B lines have a 100% concordance with CT scan. Their number, location, and extent are important. 1 or 2 per rib interspace can be normal or represent a fissure. 3 or more on the longitudinal view per rib space indicate pathology. If 7 millimeters apart, they are termed B7 lines and are associated with interstitial edema. If more profuse and 3 millimeters apart, they are termed B3 lines and are associated with ground glass opacities. 3 or more B lines are termed lung rockets. Lung ultrasound correlates well with invasive hemodynamic monitoring. A bilateral A-line pattern has been shown to have a positive predictive value for a pulmonary artery occlusion pressure less than 18 of 97%. Lack of B lines can perhaps be used as clearance for fluid therapy. Their absence indicates dry lungs. They can also be used as an endpoint for fluid therapy. The apparition of B lines occurs prior to hypoxemia and can provide an early warning of impending alveolar edema. Our final sign, the lung point, is specific for pneumothorax. You would look for this in the absence of both lung sliding and B lines, as that scenario is suggestive of pneumothorax. There are numerous causes of abolished lung sliding: pleural inflammation and adhesions, and anything that prevents adequate ventilation can abolish lung sliding. Common causes include ARDS, pneumonia, mainstem intubation, as well as pneumothorax. Both normal and collapsed lungs inflate on inspiration. If the collapsed lung has contact with the chest wall, a slight increase in contact will occur on inspiration. At the boundary between aerated lung and pneumothorax, you can see a sudden, fleeting pattern on inspiration. This is the lung point. To find the lung point, start on the anterior chest and shift the probe laterally until the lung point is seen. The lung point location is associated with pneumothorax size and need for chest tube. The more lateral the lung point, the more substantial the pneumothorax. In one study, 8% of patients required chest tube placement when anterior. 90% required chest tube placement when the lung point was located laterally. The picture on the right is the M-mode correlate of the lung point. Now we will discuss how to incorporate thoracic ultrasound into a standardized rapid approach to the bedside diagnosis of respiratory failure. To do this, turn on your ultrasound machine and place the probe at the upper and lower blue points. Identify the ribs and pleural line. Search for lung sliding, A lines, and B lines. Then place the probe at the PLAPS point and look for consolidation and pleural effusions. You would then repeat this process on the opposite side of the chest, and you have generated a specific profile of your patient's respiratory failure. In 1 minute, you have identified the presence or absence of interstitial syndrome, pneumothorax, pleural effusion, and most alveolar consolidation. Add a lower extremity venous ultrasound exam for DVT, and you have the essence of Liechtenstein's blue protocol. The protocol correctly diagnosed the cause of acute severe dyspnea with greater than 90% accuracy in a population of 260 patients with this distribution of disease in the absence of any clinical data. To finish up the talk, we'll quickly go through 4 cases. Our first patient is a 45-year-old male with a history of tobacco abuse and cardiomyopathy who presents with a several-day history of increased shortness of breath. You fire up your pocket ultrasound machine and perform a quick exam. With the linear probe, you see lung sliding at the upper blue points bilaterally, excluding pneumothorax. With the phased array probe, you find a predominant A-line pattern bilaterally. There is no evidence at the PLAPS point for consolidation or pleural effusion, and you are more confident in your diagnosis of an acute exacerbation of COPD. Your next patient is a 204-year-old Wookiee with a history of Marfan syndrome. He presents with acute onset of right-sided chest pain and dyspnea. You palpate his chest and note crepitus. You place your probe anteriorly and see this. I include this example as a reminder to always identify the ribs and bat sign to locate the pleural line. These are not B lines, but are E lines, and they're generated by air along muscle fascial planes. This is an ultrasound finding of subcutaneous emphysema. It is not lung ultrasound. You then move your probe laterally and see this, the lung point, diagnostic of his pneumothorax. His symptoms resolve after small bore chest tube placement. Our next patient is an 87-year-old nursing home resident with metastatic renal cell cancer who is admitted with fever and shortness of breath. Chest X-ray and chest CT reveal massive effusion. A chest tube is placed and drained 700 milliliters without subsequent output. Placing an ultrasound probe at the PLAPS point shows this, a complex multiseptated effusion. TPA is instilled and the tube is clamped for 1 hour. It drains 2 liters of fluid immediately when unclamped. Repeat ultrasound demonstrates dramatic improvement. Cultures grow gram-negative rods. This is a good example of the ability of ultrasound to characterize the nature of pleural effusions. Our final patient is a 600-year-old morbidly obese male with a history of COPD and congestive heart failure, who presents with acute hypoxemia and dyspnea. His chest x-ray shows a lot of soft tissue. Ultrasound demonstrates profuse anterior B lines. You start therapy for decompensated heart failure with BiPAP and Lasix, and withhold steroids. The B lines decrease and resolve on serial ultrasound over the next 24 hours. Thank you very much for your time.